describe the pacemaker action potential, which occurs in the SA and AV nodes, and it delivers the signal to the to the ventricular action potential to contract the ventricle. Some important things to notice is there is no phase 1 or 2 plateau phase in the pacemaker action potential. As I've drawn the ventricular action potential here. So let's start off with, so the first thing you'll notice is the threshold for the pacemaker action potential is negative 40 millivolts, whereas the threshold potential for the ventricular myocytes is 0 millivolts. So what does that mean? You need less negative charge to reach the all or nothing action potential. So in phase 4, we have what's called a funny current. It's responsible for the slow influx of Na plus and K plus ions, which account for the automaticity of the SA and AV node. So these leak slowly to control the heart rate. They are unlike in the ventricular, where they need to get to the positive threshold quickly. They leak slowly. One, because you don't need a super fast heart rate, whereas you need a good contractility. So once they reach about negative 40, you get to phase 0, and this is where your voltage gated calcium channels open. And much the same way, your fast voltage calcium channels produce the conduction velocity. But because of the less negative resting potential of these cells, the conduction velocity is slower to send the signal from the AV node to the ventricles. It prolongs the transmission of that conduction signal from the atria to the ventricles. Another big point, high yield. Those of you going for a 250, I'll circle here. The fast gated sodium channels are permanently inactivated in the pacemaker nodal cells because you don't need them. The threshold is minus 40 millivolts. You don't need to get to that positive threshold potential. So that's a very big difference. Also, this is a very big difference. There's no phase 1 and 0. Now, phase 4, another thing important to mention, this automaticity, it's the SA and AV nodal fibers, the pacemaker, they fire autonomously from the brainstem cranial nerves. Therefore, if a patient is on a ventilator, their heart's still breathing, but they have brainstem death, it can be very hard to explain to families that their loved one is deceased, because they'll say, what do you mean their heart is beating? But the heartbeat is not connected in any way to the brainstem cranial nerves. It beats autonomously from the midbrain. That being said, let's move on to so we just talked about phase 0, the voltage calcium channel is open. The fast gated Na plus channels are closed, because if they were, let's say they were open, you would go like, if they were open, you would go like way like that, and you don't want that. So the fast gated channels are closed. And in phase 0, this is the upstroke. The less negative potential allows for the prolonged transmission to the atria to the ventricles. Okay. So phase 3 is basically where the calcium channels are inactivated, and K plus channels are opened for the efflux to get that potential back to more negative, so it can start the process all over again. One important thing to know is that, so your SAAV node controls heart rate, and that makes sense because it's the signal for the ventricular myocyte action potential. What drugs increase heart rate? That will be so we got a decrease heart rate and we got an increase heart rate. Well, the decrease heart rate is going to be adenosine. And ACH. The things that are going to increase the heart rate. Any sympathetic activity, illicit drugs. Which is why we give adenosine in supraventricular tachycardia when the heart rate is in the 250s. Patients describe it as a sense of doom and crushing chest pain, and it works almost immediately to restore normal sinus rhythm. Now, I'm talking about increase and decrease heart rate. So what determines your heart rate based on the graph is the slope of phase 4. I'm not going to write it down. You already know this is minus 40. So Sorry for the horrible drawing. Bear with me one moment. So, very important to note that the slope of phase 4 here is what is going to determine heart rate. And that's very simple to understand because this is the time axis. So let's say a patient comes in with supraventricular tachycardia and their heart rate is very fast. Do you think that their slope is going to be steep or not steep? Well, the slope of their phase 4, it's going to be like this. Sorry, let's draw that. The slope See, I'm drawing the slope. It's very high. So as you can see, this is about 1, 2, 3, 4, 5, 6, 7, 8. Let's call it 9 pacemaker action potentials from the AV node to the ventricles in 4 seconds. Let's see, what is that? That's about, ooh, so that's about 150, 180. So that's about supraventricular tachycardia. So as you can see, this slope is high. Now, let's see what happens when the slope is decreased. Look at this decreased slope 4 compared to how steep this slope 4 is. And basically here, you can tell you got one heartbeat in about 4 seconds. That's pretty bad. Let's see, 5 times 2 is 2 heartbeats. That's about 12 heartbeats a minute, but you're going to have to give them some catecholamines. But this is just to demonstrate the basic concept that the heart rate is dependent on the slope of phase 4. I hope you found this video useful. Please ask any questions, comments, and if you feel a correction needs to be made, please voice your correction if you're interested in cardiac physiology. And I hope to see you again. Thank you.